Okay, thank you everyone for having me today. I'm Sabihah. I'm a pediatric emergency medicine fellow. At the moment, I'm based in Hospital Tunku Azizah. So for the next hour, what I would like to do is capture your attention on talking about a very common presentation in the emergency department, certainly in the pediatric emergency department, on wheezing in a population where they do not have any worry in the world. Lots of giggles and maybe a bit of tantrums. And this is the groups where the preschool population. But unfortunately, they are really predisposed to wheezing. So the next hour, we'll be talking about preschool wheezing management in the emergency department. So my outline is, we'll go through some definitions, and then we need to explain about some preschool wheeze phenotypes, and the management of acute preschool wheezing, and some long-term considerations that we should think about in the emergency department. Next, we'll go through some case discussions of different preschool phenotypes and how to manage them. Right, let's go to some definitions. So wheezing is usually described as a high-pitched whistling sound with musical quality coming from the chest, and usually during expiration, but sometimes can be heard in inspiration. So I actually have an audio clip there, but unfortunately I can't play it here. But for us in the emergency department, I hope that you must have listened to the sound of wheezing. And when I'm talking about preschool wheezing, this is basically wheezing that is occurring in a certain age group, which is between 1 and 5 years of age. So not less than 1 year old, where bronchiolitis is usually the cause of wheezing, and not in the older age, which is more than 5 years old. Right. So why is wheezing special in this preschool population? Because it's very, very common. So these 3 kids over here, which are my family members, and like preschoolers, they are probably entertaining themselves, looking at some insects down there. But 1 out of 3 of them will have a wheezing episode by the time they are 3 years old. And 2/3 of them will have a wheezing episode in 6 years old. And by the time they're 6 years old, 2/3 of these children will stop wheezing. So it is a different subtype of wheezing compared to older children wheezing. And post-COVID, hospital visits have increased for preschool wheezing. So we must be quite good at managing preschool wheezing at the moment. So why does children wheeze differently compared to adults? So I found this good explanation in this paper called A Simple Model for Understanding the Causes of Pediatric Wheeze, which was published in 2019. And basically, it can be explained in terms of the type of immune responses that is developed at different ages. So don't worry, this is probably the only slide that has anything to do with immunology or pathophysiology. So basically, just look at the second row. So in early infancy, basically, the immune system is not well developed yet. The child predominantly relies on the maternal antibodies, and basically the infant's own response is actually muted. They are not really able to mount their own immune response. So the typical features here is that they may get viral infections, but because of their response is usually muted, they don't really get a hyperresponsive or allergic reaction. It's very rare. And usually the typical cause of the wheeze is bronchiolitis. So in the preschool population, which we are talking about today, so the child no longer can rely on the mom to give the antibodies. It's actually leaving, but the child is not yet developed a learned immunity. So what it does is that they overcompensate by extreme response to an infection. So usually at this age group, they will have very vigorous responses to infection, and this can be marked in a typical cause of wheezing is the viral wheeze. However, in this age group, they are still at the transition period, so they may have a population who have bronchiolitis And some of them actually has developed a more complex immune system and may develop asthma by this age group. So, but these are just a smaller population. And while the child who is older will be able to rely on a more complex immune response, and they are be able to respond based on their information which was gathered earlier from pathogens or allergens that was previously encountered. So during this time, there'll be atopy of many forms. So the response is somewhat like an adult, so which is where we are a bit more confident in diagnosing asthma. Okay, so from there we can actually probably plot what is the incidence of the most common cause of wheezing based on age group. So in the infancy, it's probably bronchiolitis. And in the preschool group, it's more likely to be viral wheeze, but there is a small population who has bronchiolitis and some who may have early asthma. And by the time they're school age, we're more confident to say they have asthma, right? So it is also important to recognize the phenotype of the preschool wheeze. So based on the mechanism, if there's an inflammatory response, that is usually causing bronchiolitis, and that is actually a viral infection. So when there is bronchospasm, it can be either viral-induced wheeze or asthma. And in viral-induced wheeze, we can actually term it as episodic viral infection. And in a case of a multi-trigger wheeze, then we can attribute it to a progression of asthma. So it's very important to recognize the phenotype of the child because it can guide your treatment plans. But of course, we have to understand that wheezes are not just asthma. Of course, there are many other things, like any anatomical malformations, like tracheoesophageal fistulas or melasic airways, any host defense defects such as cystic fibrosis, any recurrent aspiration. So GERD is kind of a common mimic of wheezing in preschool children. And of course, any perinatal disorders such as chronic lung disease or bronchopulmonary dysplasia. Of course, we have to think about anything that can close up the airways, such as foreign body aspiration or any mediastinal mass. Okay, so if any child who was referred to you or has been given a history of wheezing, obviously one of the things that needs to be taken is a thorough history. So first thing is to know the duration of symptoms is very important. Sometimes the acuteness of the symptoms can direct you to whether it's a viral-induced wheeze or is it bronchiolitis or is it pneumonia. And if there is a history of preceding upper respiratory symptoms or anyone who's unwell at home, it's very helpful if they have any history of wheezing episodes and what was given in terms of treatment and what worked and what did not. And was there any previous HDO or PICU admission or any critical care management? So that would probably give you an idea how fragile this child could be or how this child might get a severe exacerbation. Any previous use of salbutamols or preventers might direct you to probably if they are responsive to a bronchodilator. Of course, children who have difficulty breathing might impair their feeding. So it's important to look at their feeding history and whether you have to supplement this. Growth and development is very important because any chronic lung disease or any chronicity of any diseases will impair growth and development. Any personal or family history of atopy will direct you towards probably asthma. Any interval symptoms will also direct you towards asthma. It's more important to take some history about smokers at home because this is an opportunity for you to give some advice regarding stop smoking to the parents. And of course, lastly, it's also important to know if there are pets at home and then which may trigger their wheezing. Right, so on examination, what you want to do is basically, of course, assess how severe the disease is and risk stratify. And you can risk stratify by stratifying to mild, moderate exacerbation or mild, moderate disease, to severe disease or any life-threatening diseases. So this is based on the mental state, the speech, how if they are in terms how their activity, if they're lethargic, the respiratory effort, of course, the vital signs, the respiratory rate, the heart rate, the skin color, and of course, eventually the lung sounds, whether it's normal or is it wheezing or it's absolutely tight and it's a silent chest, or the saturations, if it's more than 90% or less than 90%. We'll talk more about target saturations a bit more later. So it's really important to re-stratify, and that will direct you towards what treatment do you want to give. So in terms of investigations, most causes of preschool wheezing is clinical. So it's not routine to do a lot of investigations, but consider a chest x-ray when you are facing with a severe life-threatening wheeze. If you have a very high suspicion for a bacterial pneumonia, maybe like the child was just discharged from the hospital recently, or you are concerned about maybe there's an underlying cardiac or respiratory disease, or you are just thinking, oh, maybe there's an alternative diagnosis. Maybe there is a foreign body inhalation. Of course, consider blood tests also in severe and life-threatening wheeze, and you can take your VBG, FBC, urea, and electrolytes, and CRP. So please think hard whether you need to do this. Some or most of the time is unnecessary. So let's go straight to management of preschool wheeze and what works and what might not work. So number one, salbutamol, or the short-acting beta agonist, is recommended for all preschoolers with wheeze from the age from 1 to 5. And this is a grade A recommendation. So here I have written what are the doses that is recommended as a metered dose inhaler or nebulized. Also, sometimes people order salbutamol as a burst therapy, and how it's done, whether by administering 3 doses of MDI, either 6 puffs at 20 minutes intervals. And when somebody orders a continuous nebulized salbutamol, it's a continuous salbutamol nebulized over usually 1 hour, and you replenish every time the reservoir is empty. So there's a lot of talk about MDI and spacers versus nebulizers. And I think in this era of post-COVID, I think we are more comfortable using the MDI. And this is quite true, and it is also evidence-based that the MDI is preferred because it has similar efficacy as giving a nebulizer, yet it's faster because you can give it your 6 puffs, probably at least less than a minute or 2 minutes. However, when you nebulize a kid, it is quite difficult to get the child to sit still for at least 10 minutes. So, and of course, giving an MDI through salbutamol by the MDI causes less facial and oropharyngeal deposition of the medication. So there will be less systemic side effects from the salbutamol. But do think nebulizers are probably used when the children are struggling to breathe, they are unable to coordinate taking a deep breath through the spacer, or the child is hypoxic and you have to deliver oxygen-driven salbutamol. All right, so no questions, salbutamol is the first line for preschool wheeze. Number 2 is ipratropium bromide. This is quite established treatment for asthma, but not so much in preschool wheeze. So it's not routinely recommended. There's not much evidence for it. So, but consider for children with having severe symptoms, you may want to add your salbutamol, MDI, ipratropium bromide, or in combination of salbutamol in the nebulizers. And those are the doses that we recommend. What about oral corticosteroids? Now we're going to go into a little bit of controversies or sometimes differences in practices. So there's a lot of evolving evidence regarding using oral corticosteroids in preschool wheeze. So it started out with quite a randomized control trial in 2009 by Paniker et al., and which found there was no significant difference between the placebo group and the mild to moderate viral-induced wheeze. And in 2013, there was also another RCT done, and they showed no difference between the placebo group and the severe viral-induced wheeze. Okay, so things changed a bit in 2016. There was a meta-analysis and systemic review showing that maybe there was some clinical benefits in severe preschool wheeze. And the latest studies was actually a randomized control trial in 2018 in Perth. But it was only a single center showing that there might be some clinical benefits from treatment with systemic steroids in the preschool wheeze. In particular, they tried to prove that there was reduced length of stay. However, when you compare the length of stay that was in this trial was about the same in other studies, probably about an hour or two difference in length of stay. So is it worth it to give oral corticosteroids in a preschool wheeze? So the recommendation is that it's only recommended for severe and life-threatening symptoms, a history suggestive of an asthma phenotype, such as atopy or any maternal family history of asthma, you may want to consider it. But it's not currently recommended for children who present for the first time or infrequently with mild to moderate wheeze. And usually what is practiced is we're giving prednisolone of 1 milligrams per kg over 3 days, but sometimes can be extended to 5 days if the child is symptomatic after 3-day course. I'd just like to highlight about whether there are other options of oral corticosteroids. And this was a meta-analysis done in 2021 regarding the comparison of using dexamethasone oral, 0.3 milligrams per kg a stat dose, versus giving prednisolone 1 mg per kg over 3 days. So from this meta-analysis, they found that there was the risk of vomiting was a lot lower in the dexamethasone group compared to the prednisolone group. The problem with prednisolone is that it doesn't taste so good, so children vomit it quite a lot. And in comparison to dexamethasone, sometimes it's actually used as an antiemetic. So, but dexamethasone is probably not easily available, especially in the community clinics. So, and they found it was not showing that dexamethasone was better than prednisolone, but it was just a non-inferiority study where there was no difference between hospitalization rate, ED revisits, hospital admissions, or the amount of bronchodilators which was given. So I think it goes back to your center, whether you would want to spend a bit more money to give dexamethasone, just to cause, to reduce the amount of vomiting when you give prednisolone in this preschool wheeze. But why are we so concerned about prescribing steroids? So basically, the common concern is growth retardation. Of course, there is a recurrent high dose of inhaled corticosteroids can lead to significant risk of growth suppression. And observational studies have shown that 1 in 5 children who has had 4 courses of systemic steroids per year can cause suppression of the hypothalamic pituitary adrenal axis, and this growth will impair their growth, but actually it is just in the sub-centimeters. So it is not a lot, but I think as much as possible, do practice evidence-based medicine. Of course, there are other concerns of oral corticosteroids, such as sleep disturbances. They cause behavior disturbances, of course, vomiting, gastritis, flushing, dry skin, osteopenia, and of course, there increases the risk of pediatric fractures. Okay, number 4, managing the preschool with oxygen. So yes, we should give oxygen when it is needed, but at what point of saturation is not really, there's not much consensus on, there's not much evidence to define what is the optimal SpO2 target, which we should decide on. What we can decide is that in most guidelines, the consensus is that SpO2 is of 94% or above. And this is basically because they are trying to reference the oxygen dissociation curve, where at a partial pressure of probably about 60, where the saturations of 91%, it can easily drop and reduce the oxygen partial pressure. So at the safe level, it's usually about 91%. And given that a child who has febrile illness, there's increase in temperature, and maybe has some acidosis, this ODC curve will actually push the curve to the right. And so to be more conservative, we would accept as SpO2 of 94%. So this is also really depending on our local practices. I think in Malaysia, we would probably want to have even a higher saturations that we can accept, probably about 95% and above. Low flow oxygen should not be given to children just because there is some work of breathing in isolation. So probably this is something a bit more practice changing, but I agree that having low flow oxygen would not help much in a child who has some work of breathing. And desaturations, which is just less than 5 minutes during maybe sleep, and self-corrects, also does not require you to increase or commence supplemental oxygen. So in these children that you start oxygen therapy, this pulse oximetry monitoring must be started for them. Okay, what about IV MEG sulfate? So IV MEG sulfate is very established in the management of asthma because in theory it decreases the uptake of calcium by the bronchial smooth muscles, and that causes the bronchodilation. But in a study in 2018, which was an RCT, and it studied on the use of IV MEG sulf in children with viral-induced wheeze, and they had persistent wheezing after giving inhaled salbutamol therapy. So they randomized to either a bolus of MEG sulf or saline, but they found no significant difference in both outcomes. So basically, IV MEG sulf is probably not recommended to be given for the mild and moderate disease of preschool wheeze, but more for the severe or life-threatening respiratory distress. And IV MEG sulf, we are used to the dose of equivalent to 5 milligrams per kg given over 30 minutes. Be careful, especially with IV MEG sulf, is the severe reactions such as hypotension and respiratory depression, and sometimes they can go into circulatory collapse. So these patients must be monitored very closely. What about intravenous salbutamol? Also, the recommendation is only for children with very severe acute wheezing, not responding to bronchodilators and IV MEG sulf. So medications that is not routinely recommended anymore in acute preschool wheeze, I'll just write down here, which are the hypotonic saline, oral beta-2 agonist, which I find that has gained less and less popular nowadays because of the systemic side effects. Inhaled corticosteroids is not routinely recommended in the acute phase of preschool wheeze, or intermittent Montelukast. But sometimes, us in ED, we must think about what is the chronic management for maybe multi-trigger wheezes, and some of the medications that probably we can't start in emergency, but something that we may need to refer to our pediatricians or our family medical doctors are inhaled corticosteroids for the multi-trigger wheeze, and they usually recommend starting a 3-month trial, or the Montelukast, which is your leukotriene antagonist. And Montelukast can be considered as an alternative to your inhaled corticosteroids for toddlers, especially for the ones who are not going to comply to your inhaled corticosteroids. But of course, as usual, when you prescribe Montelukast, parents should be counseled regarding the potential side effects, especially the headaches, and of course the night terrors, the mood disturbance, and the depression. All right, we talk about most of the drugs that is usually used in preschool wheeze. And now we go into, so you have given your salbutamol. So the next thing is, when do you give your next dose of salbutamol, and how do you practice this? Or basically, how do you stretch your salbutamol? So we know that salbutamol half-life is about 2.7 to 5.5 hours. There's no exact science how you do it, but it requires you to do hourly assessments. And your stretching or stretching your salbutamol interval should be based on the respiratory distress of the child, the activity level of the child, the respiratory rate has come down to normal rates, the heart rate has come down to normal rates, the speech is better, the child can speak in full sentences, the auscultation, the wheezing has improved, or just having wheezing does not mean that you need to give salbutamol, but the air entry is better, the wheezing is better, and of course the oxygen saturations have improved. So there are two ways how people do it. How I do it, or how a lot of people do it, is basically when you start a salbutamol, then you try to stretch it by only giving salbutamol when the symptoms return. So if you give a burst of salbutamol at a certain hour, the next hour you reassess back the child. Say the child has become better, lungs is clear, child is not tachypnic, so you don't give any more salbutamol, you then stretch to 2 hours, and you do the same reassessment until, say, if the child does not require any more salbutamol in 4 hours and fits the discharge criteria, the child is able to be discharged. But some people actually do a prescriptive type of salbutamol stretching, and this is usually when your emergency is very busy. You don't have the luxury to review the child every hour. So what you do is, okay, I'll give salbutamol next hour, and then for twice, and then you give a prescription for another 2 hourly. So this is usually when you do not have the luxury to monitor the child every hour. So actually, there is no difference between both practices, but these are based on very, very small studies. So if you have the time, I would actually encourage you to use just dosing the salbutamol when the symptoms return, and you may be able to clear your emergency a bit faster. Okay. So in terms of disposition, when should you consider discharge from the emergency? If the child meets all the following. If the child is well and requires a salbutamol no more frequently than every 4 hours, if the saturations is greater or equal to 94%, child is eating, drinking well with normal hydration, and the parent and caregiver is confident to take care of the child at home. And maybe you have to consider a longer period of observation for maybe the well child, but they have high-risk features. They had history of sudden deterioration or an admission or history of admission to the critical care. Okay, in terms of discharge package, this is what we should propose, and something similar to an asthma package discharge. So what you see in front of you is what is available in the Children's Health Queensland in Australia. So they have a wheezing action plan. They have preschool wheeze education to parents, such as leaflets and also videos. We need to check the inhaler technique via the mask and spacer, and of course we have to arrange for follow-up appointments. So in terms of the preschool wheeze action plan, this is what I found in the Malaysian Pediatric Asthma CPG in 2015. So I understand that there is the new pediatric asthma CPG is in the works. So this is a bit outdated, but you may use whatever you have at hand. But one thing that I would like to just point out in this asthma action plan is that it doesn't tell you what to do just after discharge. 6 puffs every 4 hourly or 2 puffs every 4 hourly. It doesn't do that. It just tells you how many puffs you should take when you're well, or when you're having some symptoms, or when it's an emergency. So this asthma action plan does that. You have a discharge action plan for the first few days after discharge from hospital, and then you have an everyday action plan. I think this is probably more useful for us in emergency. So with all the evidence that I have, told you, this has been summarized in a flow chart of preschool wheezing by the Queensland Health Department. So I think I won't go into much detail about this, but you can actually visit the website and that link to see how they re-stratify the child and direct their management for all preschool wheezing. Okay. So next, I'll go through some cases and see whether we can apply whatever that we have, I've gone through in terms of our management for preschool wheezing. So the first case will be Fatin. She's a 1 year and 2 months old girl and born term. She's current weight is 11 kilos, so she's thriving. Mom said brought to the hospital because she was having some coryza symptoms for the past 3 days. Initially, the coughing was just dry with some low-grade fever. Started yesterday, and now today she has been having some increased work of breathing. Mom said that the child has been having some interrupted feeds. Clinically, she has been having some moderate subcostal recessions. Her respiratory rate is 40 breaths per minute. Saturation is good, it's 99% under room air. On auscultation, there is some scattered crepitations and rhonchi bilaterally. So what are we thinking about in this age group? Can we give a phenotype for this child based on the symptoms? So this is a classic case of what we call bronchiolitis, basically, and you'll think it matches what I'm going to describe you. So basically, it is a common lower respiratory tract infections under 2 years old. So bronchiolitis, there's an overlap in this age group of less than 2 years old. They may fall in the preschool age population. The most common culprit is RSV, which is 50 to 80%, and other viruses. Okay. The natural cause usually is that it usually starts with the upper respiratory tract symptoms, and then usually some fever, rhinorrhea, a bit of coryza. And later on, the child will develop moist cough, increased work of breathing, wheezing, and tachypnea. Then that's when the lower respiratory tract has actually been affected. So not uncommon, they will have some decreased oral intake due to the work of breathing. And in very young children, but not in our group of 1 to 5 year olds, there will be some apneas. So on auscultation, there will be some wheezing and transmitted sounds and fine crepitations. Usually, it lasts about 7 to 10 days. So this is something that you can try and when you explain to parents what is the cause of the illness. But the worst will be, the most severe is the night of the second night and the third night. So if you have a child who has presented to you very early at day 1 or day 2, be careful about discharging them, or you may have to warn the parents that this is going to get even worse until they get better. Cough sometimes can last up to 4 weeks. So a bit of bronchiolitis pathophysiology. So in bronchiolitis, rather than just straightforward bronchoconstriction, what happens is that there will be some necrosis and loss of the epithelium. There will be inflamed tissue. Some of the alveoli will be collapsed, and some of the alveoli will be overinflated because of the trapped air. Some of the risk factors for severe infections will be age of less than 2 months or 8 weeks. If they have any congenital heart disease, neurological conditions, they have any chronic respiratory illness, pulmonary hypertension, ex-prem infants, any inborn errors of metabolism, Down syndrome, cystic fibrosis, any immunodeficiency, or if they have any previous admission requiring NIV or PICU admission. So these are no-brainers, basically, that even though they are well, you might need to observe them a bit longer. And how would you manage her? So, like I said, oxygen supplementation, keep it more than 94%. In bronchiolitis, there is good evidence to even start on high-flow humidified oxygen via the nasal prongs. Any flow rates, which is about 2 liters per kg per minute, will provide about a PEEP of 4 to 8 cm. And you can start some nasal suctioning, which may be performed at scheduled intervals, which has been proven to actually decrease the length of stay. But be careful not to do deep suctioning or nasopharyngeal suctioning, because that will increase the airway edema and increases the length of stay. So what about bronchodilators in bronchiolitis? We heard about this, that bronchodilators do not work in bronchiolitis, especially in our PREDICT, which is guidelines, which is a working group in Australia, showing you the best evidence of treatment. So PREDICT does say that there is not to administer beta agonists to infants, but not much can be said about children who is more than 1 year old with bronchiolitis. So there could be an overlap syndrome of acute bronchiolitis with episodic viral wheeze. So bronchiolitis may still be used, but if you want to use it, please reassess back again and actively monitor the response. So next will be hydration. So as children may have some impaired feeds, so encourage some small frequent feeds. But if feeds are worsening, you may ask to ask to put an NG feeding. But please remember that ill children are susceptible to SIADH and hyponatremia, so don't overload a lot of fluids. Most of the time with children with respiratory illness, we start, if they are not in dehydration, we start them on 2/3 maintenance of normal saline D5. But there is inconclusive evidence for bronchiolitis for nebulized hypertonic saline and nebulized adrenaline. So this should not be routinely administered to children with bronchiolitis. Okay, so Fatin has grown up. So she's now 2.5 years old. She presents to the ED with shortness of breath and wheezing. And she's been picked up from the nursery because the staff noted that she started coughing and becoming wheezy. And she has a history of wheeze, which resolved with Salbutamol. So that's really important to know. She had fever and cough since this morning. She's born term. She's fully immunized. There's no allergies. She has an older sister, aged 4 years old, who is well. Father smokes outside the house. She has no interval symptoms, no atopy, but the mother has a bit of allergic rhinitis. Otherwise, she's been drinking and eating well. So on examination, she's quite well. She's slightly tachypneic respiratory of 32 with a heart rate of 120. Saturations are fine. She's afebrile and she's well hydrated. You can see some mild intercostal and subcostal recessions with bilateral wheezing. Otherwise, every other systems are actually quite normal. So what's your working diagnosis? So viral-induced wheeze probably fits most in the history. Asthma, well, there's no suggestion of interval symptoms. It could be allergy or anaphylaxis, but that's really unusual not to have any mucocutaneous response. It could be a foreign body inhalation because it fits. It's quite sudden, isn't it? But there was no witness choking or aspiration. But you don't really wait for that history in children. If it's pneumonia, but the history is too short. It's just that day that she was having some cough. And it's unusual to only have wheezing without any crepitations in pneumonia. And is it cardiac failure? The history is too short. There's no signs of cardiac involvement on the examination. So viral-induced wheeze occurs 1 to 5 years old, and the peak is about age 3 years old. So you don't really want to call someone who has viral-induced wheeze outside of this age group. Whatever viruses that cause bronchiolitis can cause viral-induced wheeze. And usually the symptoms is acute wheeze just after they had some upper respiratory tract symptoms. And most importantly, in viral-induced wheeze, the child does not have any respiratory symptoms between episodes of viral infections. And on auscultation, the wheezing is bilaterally and responds to bronchodilators usually. So what would you do for the patient? So from what I presented, would you prescribe any oral steroids? Would you prescribe antibiotics? Maybe would you prescribe some short-acting bronchodilators via MDI and spacer? Would you order chest X-ray and blood investigations? Would you do all of it or none of the above? So, I don't have a quiz here, but I hope I have converted you after what I've presented and probably done what is best for the child. So we have actually re-stratified this child. It looks like a mild to moderate disease of viral-induced wheeze. So yes, you should give some bronchodilators, so give some MDI salbutamol, 6 puffs via mask and spacer, and then maybe you want to reassess in an hour and stretch the salbutamol. There's no role for oral steroids and no role for antibiotics because it's a viral-induced wheeze. And obviously, there's no need to order chest X-ray or bloods. You may want to refer to KK for follow-up. May require inhaled corticosteroids or montelukast as this is a recurrent or episodic viral-induced wheeze. What about the third case? This is a bit ill child. This is Wilson. He's 3 years old. He has cough and noisy breathing today, and he had a recent upper respiratory tract infection. And clinically, he's tired looking, he's coughing, and you can hear audible wheezing. There's deep, deep recessions. On auscultation is a silent chest with widespread wheeze. His respiratory rate is 36, which is okay for his age, but be careful that probably the child is getting more tired. The saturation, the child is hypoxic on room air, 88%. His tachycardic of 150. His blood pressure is holding up, and he's slightly having a low-grade temperature. So on further history, he just had a fever and cough this morning. Otherwise, he's born term, fully immunized and no allergies. He has a sister who has got asthma. The father smokes outside the house. Usually, the father, every smoking history, usually mothers are very defensive that the husband actually smokes outside the house. The child seems to have exercise-induced cough for the past 1 year, and he has also eczema, and the mother has allergic rhinitis. So what are we dealing with, basically? So looks quite a severe presentation, but in terms of the phenotype, it looks like there is a multi-trigger wheeze going on. So this is when the preschool wheeze occurs during discrete episodes, but also symptoms between those episodes, and the triggers are multiple. There is a possible evolution that it may actually lead to asthma, but there's actually quite poor evidence to support this, that multi-trigger wheezes actually progresses to asthma, because a lot of wheezing actually stops after 6 years old anyway. So it's very if anything, that we get from today is very difficult to diagnose asthma in the preschool age. So how do we decide whether this might become asthma? So it's not just by the symptoms, but sometimes we can use a probability-based approach in diagnosing asthma. Hope maybe you may have heard of Modified Asthma Predictive Index, or the Modified API. So you need 4 or more wheezing episodes in a year, with 1 major criteria or 2 minor criteria. So the major criteria will be there's a heavy burden towards having a parental history of asthma, or there is some eczema diagnosed by your physician. And the 2 minor criteria will be a physician diagnosing allergic rhinitis, wheezes without colds, or the blood eosinophil count of more than 4. What you're probably more familiar is what you call the GINA asthma probability score, which is also seen in the pediatric protocol. So it's quite the same. It's based on the amount of symptoms. So it should be 4 episodes or more than 3 episodes per year. And it does describe more what are the symptoms and what is the duration of symptoms, and whether there is any atopies. And you may be able to classify whether the child, most of them have asthma, some may have some have asthma, or few may have asthma. So this is still in the GINA guidelines in 2022. So how would you treat this child? So as usual in the emergency, we try and risk stratify, but I just want to highlight that there are quite 2 validated scores that probably is used in your center. In Hospital Tunggal Aziza, we use the pediatric asthma score to probably differentiate whether it's a mild exacerbation or a severe exacerbation. Other centers will use the PREM score, which is also widely used. What I like about using these scores is that it's actually more objective. We have a score for it, and when you treat the child, you may use the same score to see whether you have the score has actually reduced and you're actually at the right track. There are some studies, there isn't actually a study trying to compare whether a PAS score is better or more sensitive rather than the PREM score. So how would you manage this child? So let's go back to management flow of the preschool wheeze. So this child will be under life-threatening asthma, life-threatening preschool wheeze. So you can go to the most right flow, where you use salbutamol nebulizers and consider giving steroids, magnesium sulfate, and maybe consider high-flow nasal cannula. So this is what I've just said. So you might want to give continuous nebulization of salbutamol and Ipratropium bromide. You need to put an IV access for steroids. You may use hydrocortisone, methylpred, or dexamethasone. There's no, in terms of studies that it has done to compare whether which steroids is better. So far, it has been quite equal in terms of efficacy, It's not so important to use which kind of steroids, but it's more important to know what time you start your steroids. So the earlier the steroids go in, is the better. So it really depends on your nurse whether they're familiar using hydrocortisone. If that's what's available and they're they're happy to actually prepare it, then use hydrocortisone rather than using the high-flow medications. Methylpred is probably more familiar in the PICU setting. So you reassess after 30 minutes, and then if the child responds, you can wean your salbutamol. But if there's no response, you may have to go to your second line or third line medications. Obviously, if there's no improvement, you have to think about non-invasive ventilation or mechanical ventilation and refer to PICU. Okay, that's basically it in terms of asthma or multi-trigger wheeze. I just wanted to point out in terms of, for us, when we want to discharge children with asthma, in GINA guidelines are a little bit different in terms of what we want to prescribe as a controller. Look at step 1. Even for intermittent or mild asthma control, the preferred control used to be before this not to start any control, any preventers, MDI preventers for this group. However, the new GINA guidelines actually are starting to use a short course of inhaled corticosteroids for when the child is having a viral illness. So maybe you have to consider that for all children who has or you have diagnosed with asthma. Okay, my last case will be Ahmad. He's 13 months old, and he started having cough and noisy breathing for today. There's no rhinorrhea, there was no fever. Relatively well this afternoon. There's no pets or smoking exposure, no past medical history, and he has been immunized up to date. He's active and playful in your ED. There's no stridor, but you can see moderate intercostal and subcostal in drawings. And you can see some wheezing on the right lungs with reduced breath sounds. So otherwise, ear, nose, and throat, just normal. Otherwise, vitals are relatively normal. So what are you thinking in this case? Could it be what previous cases? Is it a bronchiolitis, viral-induced wheeze, or any pneumonia? Especially when there's wheezing on the right lungs with reduced breath sounds. So you still can use the same approach about preschool wheeze. So this could be a mild disease. But one thing that is that strikes out in the history is quite atypical. So you might want more. So the atypical history is that there is it's quite sudden, and you can have localizing signs. There's actually wheezing only on one side of the lung. So should you start any trial of bronchodilators? Yes, just proceed, but you may need to investigate. And then luckily, you did a chest X-ray for this child, and you can see that over the right side is hyperinflated, and the diaphragm is actually flattened. So there's something blocking the right side of the lung. And funny enough, you actually referred to respiratory, and they did a bronchoscope, and they saw like this, probably some peanut, which is sitting on the right bronchus. So this is actually a foreign body inhalation. So it's common, actually, children like to put their stuff in and probably accidentally inhaled or ingested in the first 3 years of life. They may present with wheezing, stridor, or cough, and basically management is removal of the foreign body. It will strike to you that this is something else, or it's not your usual wheezing phenotype when there's a lack of response to bronchodilators. So, but sometimes inhaled SABAs can sometimes be used for symptomatic relief. So my last slide is diagnosing causes of wheezing in a preschool child can be quite difficult, but yet we still need to take a good history. It's still important to make a distinction on the wheezing phenotypes to decide the right treatment. And sometimes the diagnosis is only apparent when the child responds or not to the bronchodilator. Choose targeted investigations. Many actually need nothing, and it's actually just clinical. And when you see a child, risk stratify the child's presentation to guide the child's management. All right? Okay, that's my last slide. Thank you very much.
Sorry. All right. Thank you, Sabihah. Thank you so much. That was a wonderful, wonderful presentation. I am going to ask a bunch of questions from the audience, and there are a bunch of them. So just hang in there, and we will ask you the questions.
I'm going to answer, right? Stop.
All right. So the first question from the audience is, where do I get an e-certificate? So the e-certificate is actually in the description of the video.
Okay,
You
you can
just
answer
have to
that
click.
better.
Yep. So you just have to click on the description on the video. It's there. It's in the comment section as well right now. If you've watched the video later and you still want a cert, you can still go and get it. It will deliver straight to your email. Okay, so you don't have to worry about it. Don't drive and try to fill out the cert now. Just go and do it later. It'll get to your email. Right, so the first question, and we'll start from the bottom. So, hi Dr. Sabihah, is there any respiratory severity score for viral induced wheeze?
Okay. Um, in terms of viral-induced wheeze, what I've looked around, there isn't a specific respiratory score. You can actually use your scores for PREM or for pediatric asthma scoring. That's what we do sometimes when the children come with preschool wheezing. Yeah. But in particular, just for viral-induced wheeze, I'm not aware of that. In terms of viral-induced wheeze, what I looked around, there isn't a specific respiratory score. I don't know, Dr. Suhaimi, maybe.
Okay.
You can actually use
Yeah.
your
You
I
can
think
use
there's a
the
little bit
prime
of
score.
delay with Dr. Swami.
You can-
We'll get back to him in a bit. Okay. Next question that we have for Dr. Sabihah is, hi, evening doctors. I would like to know if there was a role in Montelukast in preschool wheeze. Is this the case? Is it on a case-by-case basis, or is it better to discuss with the EP consultant prior? Thank you, doctor. So Mugilan wants to know if there's any role for Montelukast or not.
Okay, so these are your leukotriene antagonists, receptor antagonists. Basically, maybe they'll stabilize your mast cells. Unfortunately, studies that has been done for Montelukast in terms of the acute phase of the preschool wheeze, there seems to be not much benefit in starting it during the acute phase. Like I mentioned before about intermittent and Montelukast prescription. However, in terms of maintenance for episodic chronic, or recurrent recurrent wheezing in preschool children, there is a role for Montelukast. And it can be done as an alternative to using inhaled corticosteroids.
Okay, Dr. Suhaimi, do you have any opinion on that, on the Montelukast and preschool wheezes thing?
My experience in terms of Montelukast is quite great in terms of if you're dealing with multi-trigger wheeze, of course you can use, but for viral-induced wheeze, if you are reluctant to use your steroids, I think if the child, or you can just ask the parents to look at the child. If child is okay, I mean no nightmares and all, you can just start your Montelukast. It's good in terms of for you to maintain in terms of bronchodilator at night for the episodes of or period of viremia.
Yep.
Okay. So Farhan wants to know, hi Dr. Sabihah, for asthmatic patients that use inhaled corticosteroid, how do we taper down or stop the ICS, or is it a lifelong medication?
Right. I think that's more touching on chronic management of or maintenance of asthma control. So I think this will be rather than it won't be done or tapered down in the emergency department, but it's very important to be on this as ICS for asthma. And the way how Gina is going towards not only treating with bronchodilators like SABAs, but also ICS. But when to taper it will be actually in the outpatient clinics, and it depends on the control. So if you are symptom-free for the next 6 months to a year, or your symptoms has been less than 3 episodes in a year, they may consider actually tapering down or offing your ICS. So it is probably, you need to see the pattern in probably a longer term. Yeah. But it's not lifelong for sure if it's well controlled.
Sure. Dr. Suhaimi, what do you think about long-term corticosteroids for asthma patients and for our preschool users? What do you think? Is that something that we're going to start them on, some inhaled corticosteroids early and get them better?
If is it value or is it like FT, yeah? Index is high, and you are treating the patient as moderate and you are discharging the patient after you have observed the patient, I usually will prescribe and make sure that the patient will be followed up in the clinics, either pediatric clinic or the KK, and then they will do the tapering. No, you will have to start the patient actually, or else patient will come back again and with another exacerbation. So that one, I think if you are not familiar with that, you should discuss with your emergency physician.
Okay, that's absolutely a good answer for sure. Thank you. We've lost Sabihah's camera feed, but she definitely can hear us and she can definitely answer.
Yep, I can hear you.
Yep, I'll
Let's
help you
trying
get the camera.
to find out the
Yeah.
button.
Okay, I'll get you back up in a bit. Just give me a minute. Hi, evening doctors. Would you like to know if there's a role
Okay.
for Montelukast in a preschool? And we've discussed that, sorry. Good evening, doctors. Can we use oral salbutamol to replace MDI as some of the parents are not able to afford a spacer? So can we replace oral salbutamol with an MDI because some people can't afford a spacer?
Okay. Yeah, as I have spoken earlier, that oral salbutamol is not any equivalent or has causes in terms of the effect in terms of through the lungs, and cause a lot of systemic effects which we do not want to have. So I wouldn't recommend as an alternative for salbutamol inhalers. Now, in terms of affordability, okay, unfortunately, it's not something that we give for free in our emergency. So we either can give access to this by allowing, like for example, in my hospital, we actually direct them to buy the spaces somewhere near the hospital, so we can direct them. But unfortunately, we cannot subsidize that. Some emergencies I know have actually, whether they have crowd surf or they have a fund for it, such as tabung amal, or they have extras that they can give to this kind of patients who cannot afford the MDI spaces. So, or another thing is, if they cannot afford it, then get the social welfare in, basically. Yeah.
Sabihah, I can ask you a question about this. There's some places that have been using paper cups and other forms of modifications to kind of get this done, and as a temporary measure for children going home. What do you think about those?
Yeah. Absolutely, it has been, obviously they are there because obviously a lot of people cannot afford it, or cost is an issue. I wouldn't say it's as equivalent to your spaces, but if you need to, as a bridging time before they get the money to buy their own spaces, that is probably the last option that you can give to the patient, that they can go back with the paper cups. But obviously there's going to be a lot of leak, and it's not going to work or function as good as your spaces and mask.
Right, absolutely great. So we have few more questions here. Hi, good evening, doctors. Can we use nebulizer Pulmicort in management of viral-induced wheeze? I feel like this one keeps coming up. Dr. Suhaimi, you want to take that first?
Okay. Inhaled corticosteroid. There are some studies. I know in the slides just now, it's not, Sabihah mentioned, not routinely recommended, but there are some studies using it, especially multi-trigger wheeze. It's very expensive. So if you have, how to say, you have to go to your routine management, and that will complement. There are some studies for bigger children, mainly asthma. There are some studies that can reduce the admission rate for asthma children in ED. So I reserve it for someone senior to decide it, and after you have gone all through the routine management.
Yeah, so save it for some senior management to kind of decide whether that's necessary or not. Yeah. Okay, fairly good answer. That's Sabihah, sorry. Hi, many more would prefer inhaled corticosteroids as first line versus short-acting beta agonists in acute exacerbations. Your thoughts? can we prescribe MDI flixotide instead of starting MDI salbutamol stat? So, what do you think?
Um, okay. I'm not aware that it's a popular um, management to start on ICS first compared to your bronchodilators. I think first line and it's a grade A recommendation. It's proven that bronchodilators are much better and it works faster. Um, of course, Jean has included using inhaled corticosteroids together with bronchodilators but that is as a maintenance for or preventer as a preventer for management of asthma. So I'm still not in that camp of using ICS as a reliever.
Dr. Suhaimi, what do you think?
The first line is still salbutamol as a bronchodilator. The steroids are not for not to bronchodilate. It's used for anti-inflammatory. So you have to in acute setting, the answer is always salbutamol or bronchodilators. It's not steroids. All those the steroid will complement a bit later, but you still have to use your first line, which is the beta-2 agonist.
Question to both the presenters today. Salish wants to know which is better, metered dose inhaler or nebulizer? This is the big question everyone wants to ask. There's a lot of thoughts about this. Some people prefer the nebulizer, some people prefer the metered dose inhaler. So which is better for delivery of medication into the child that's wheezing?
Okay, so I think it depends on what condition the child comes in to you. For a child with good respiratory effort, or not respiratory effort, is breathing and with coordinating well. So and the child is not hypoxic. So I would still use a metered dose inhaler for the reason being, first there has been studies been comparing metered dose inhalers with nebulizers in this population of mild to moderate exacerbation, and the efficacy is the same. The efficacy is the same. However, what you get with metered dose inhalers is that it's fast. You can actually deliver it faster rather than having to hold down a child. Imagine a 3-year-old who's probably frantically probably wanting to get away from your hands or anyone from the nebulizer. So it's faster. And then, of course, it's a better seal when you use a mask rather than a nebulizer where you can have actually deposition of the salbutamol in the oropharynx, and maybe you can get some systemic effects from that. However, if the child is hypoxic and the child does not have a good respiratory effort, you can't actually rely on the child actually breathing through the spacer. You definitely have to put in deliver the salbutamol using the nebulizer.
And I think the key there being that you're trying to deliver salbutamol oxygen-driven for sure. So
Oxygen-driven, yes.
You're trying to prevent the child from becoming hypoxic. Dr. Suhaimi, which is your weapon of choice? Do you kind of err towards the side of using MDIs, or are you the kind of person that just plugs them up and bundles them up and starts the nebulizer?
I am on MDIs, not nebulizers. Are only for severe or life-threatening preschool wheeze or asthma. The other thing I just wanted to mention about that paper cup thing. Those are not aero chambers. Those are spacer. You need a good coordination between you, pressing the MDIs and you inhaling the Ventolin. So spacer is again for adult or like school age children, or more than that, like 13, 14. So less than that is always aero chamber. And aero chamber nowadays is quite cheap in terms of in the pharmacies. You can just get it in like 40 ringgit.
Right.
So aero chamber is the answer.
Yep. And if you can't afford that, I'm sure AliExpress has quite a few of them as well. For a couple of dollars you can kind of buy. That's just me though. I don't know whether they work well enough, but yeah, fair enough. Okay. Sorry, Wei wants to know, hi evening doctors, when do we choose for Montelukast, and when do we choose for MDI flixotide or Severity? Seems like a very difficult question, something we don't normally start in ED. That's a bit of a question there, but can you guys kind of try to handle
between flixotide
between
Montelukast
when do we,
and
okay, the first question is when do we choose Montelukast, and the second part of the question is when do we choose MDI, Flixotide, and Severity. So the first part is when do we, okay, which kids are getting Montelukast in your centers?
okay. Sabihah?
Okay. Okay, I'll just broach into the subject of starting preventers in the emergency. Okay, first you need time. Okay, to start any inhaled corticosteroids. You need to educate them how to take. It's not just about just puffing another 4 puffs of one puff or 2 puffs of budesonide or flixotide, right? You need to know how the risk of it, having some oral thrush and all that. So do you have time for that in the first place? So. So starting inhaled corticosteroids is sometimes I understand fully if you are very busy eating not to even start it and actually give the work to our outpatient colleagues, maybe in the clinics or in our pediatric clinics. So obviously Gina has if we are talking about asthma or preschool wheeze, there is actually a step 1, step 2, step 3 when we should start giving this second line medications for preventing. So you just have to follow that. So I think obviously is usually inhaled corticosteroids first, and then maybe the consideration later is for maybe Severity, LABA, and also steroids with the inhalers, and eventually maybe Montelukast will be considered. So there is a step approach for GINA guidelines. You just have to, I think, it's really good. If anything, anyone goes back, please read the GINA guidelines, which was published in 2022.
Take on the question is, Montelukast, if you are already diagnosed, the patient is having asthma, so Montelukast will be the third in terms of steroid. Then you use your reliever, your Salbutamol, and the third one will be your Montelukast. But for viral-induced wheeze or multi-triggered wheeze, you can complement it, especially when you are discharging the patient at night. You can just give the Montelukast for the episodes of viremia that patient is having, or episodes of URTI that patient is having. The other thing about, the second question about Flixotide and Severity. Okay, you have to look at the chronicity of the asthma, whether it's intermittent, whether it's persistent. This is clinic works lah, but I've usually when patient came in a preschool wheeze, I will start budesonide first, 200 mics BD, and then I will refer it to the PITS clinic or the KK. The Severity, I've never prescribed it for children, only for adults. It will be another step after the Flixotide started in the clinic. They will upgrade or up triage the Flixotide to Severity. So not your job, not our job. Okay, thank you.
Okay. Question to the both of you. Farhan wants to know, hi doctors, is there a recommended cough syrup to be given to a child less than 2 years old for chronic cough? I feel like this is one of those things that keeps coming up with our wheezers. They're coughing all the way, and our doctors want to know like what really will help this kind of 2-year-old. Parents have got expectations. The child's coughing away at night, so what can you do?
Okay.
Sabihah, how about you first?
Okay, I'll start first. Okay, so it's not fun having a parent who brought the child for cough and then lungs are clear, and basically you don't prescribe anything to the mom, But you do have to. Unfortunately, I don't think they have good cough syrups or symptomatic relievers for the cough itself, and you just have to tell the mother that it's usually self-limiting, and it will, and hopefully the mom actually listens to you. Unless the cough is actually secondary to a wheezing, that is something else, then you may have to start going to the preschool wheeze bucket.
don't think you can kind of deal with the cough in itself. I think you kind of try to find out what the underlying stuff is, and then kind of deal with that. If it's a wheeze, then kind of deal with the wheeze as well.
The concerns is usually the cough syrups causes a lot of respiratory depression and maybe sometimes serotonin syndrome. So anticholinergics also. So those are things that are more of our concern when we actually prescribe these cough medications.
Okay. All right. So just another 3 more questions, guys. Joseph wants to know, single maintenance and reliever therapy, SMART, would it be beneficial for children with newly diagnosed bronchial asthma? I'll let Dr. Suhaimi answer this.
Smart,
SMART, difficult.
I know about SMART. I know about SMART, but I'm not familiar with SMART. I know people are promoting SMART because of Symbicort, but Symbicort is not prescribed for less than 12 years old, so it's only prescribed after 12, right? I know. That's my understanding of SMART.
Yeah.
Right. They wanted to combine both.
There's been some new data that's kind of showing up that starting long-acting beta agonists from formoterol, i.e. Symbicort, early on is kind of helpful. But again, I haven't really seen anything. I mean, the GINA guidelines kind of err towards that side, starting long-acting beta agonists early. But we'll wait for our new asthma guidelines to kind of come up, and then we'll kind of give you guys some advice on that. How about that? Okay, thanks, Joseph. 2 more questions. Saida wants to know, good evening, doctors. Is the role of MDI salbutamol of 6-puff applicable to even less than 2 years old? 2 years old. Sabihah, I feel like we've asked this question before, and we've spoken about this. So the question is going to be, when do you give 6 puffs of salbutamol? Do you give them for a child under 2 years of age?
Okay. So in terms of the dosage of 6 puffs, so well, we feel like we give the cutoff point of in terms of dealing with wheezing in our department. We use it 6 years old is our cutoff point. So less than 6 years old, but of course more than 1 year old, we give 6 puffs of MDI salbutamol, and for more than 6 years old, we'll give 12 puffs, like adults. Yeah. Is that the answer to the question? I can't really hear you though.
Can't hear you, Karen.
Okay.
You are muted.
Still
You
muted.
are muted.
Yep, sorry. Yeah, that is me. Okay. Hawawani wants to know, can we give short-term Montelukast during exacerbations? Thank you. I feel like there's a lot of questions about Montelukast.
Yeah, everyone likes
getting
the
Montelukast out there. I mean, I know a few centers do. I know like Purple Zone, there is some going on, and we don't quite actively do it here in the PTD in HTA. But I feel like a lot of people have a lot of questions about Montelukast. Are these all your kids, Dr. Suhaimi?
Yeah, those. But what I understand about Montelukast is that you have to give it a trial of a good few weeks of Montelukast. It's not just short. They don't recommend intermittent Montelukast prescription. This is in terms of maintenance of the symptoms. But obviously, I mean, I have no experience in prescribing it as short term.
Okay. All right.
My experience on Montelukast is great. It's great. And the nightmare, I've seen it in adult rather than in children.
I see.
So, I mean, if you are, I've done it for adult and children, so it's a good experience in terms of even acute phases. But you have to treat them with the Ventolin and all before you started your Montelukast. That's my experience. Okay.
All right. Okay, guys. I think that will be it. It's almost 5:30, and you guys are probably all ready to go home anyway. Thank you so much, Dr. Sabihah, for the wonderful presentation. And thank you so much, Dr. Suhaimi, for giving us all that input today. Absolutely wonderful to have the both of you around. Thank you so much. Thank you so much, guys. We'll see you again soon. We'll have another webinar very soon. Hopefully something interesting and something different this time around. But yeah, thank you for joining us. Bye-bye.
Bye.